Hello all, I'm Dr. Kaustubh Mohite, your pediatric pulmonologist. Welcome back to my channel Pediatric Pulmonology. In this episode, we will be discussing about the main anatomical and physiological differences in infant and adult airway with its clinical correlations. So let's enlist these differences one by one. Infants have a relatively smaller nasal cavity with smaller nasal passage as compared to the adults. Hence, they are more prone for nasal obstruction causing respiratory distress. Infants are obligate nose breathers as compared to adults who may utilize both nasal and oral cavity for breathing. This adds on to the aggravated respiratory distress caused by simple nose block. Infants have a relatively larger protruding occiput as compared to the flat occiput in adults. This larger occiput causes flexion of the neck when an infant is kept in a supine position, which causes upper airway obstruction. Infants have a larger sized tongue in proportion to the size of the mouth. This factor also increases the chances of the upper airway obstruction due to tongue fall and may require oropharyngeal airway and positioning in a sick child. The larynx of the infant is situated anteriorly and higher at a level of C1 to C3 cervical vertebra as compared to C3 to C6 vertebra in adults. This is the cause of the acute angulation between the base of the tongue and the glottic opening. Hence, a straight laryngeal blade is preferred in infants during intubation as compared to a curved blade in adults. Epiglottis in infant is large, floppy, and omega shaped. Hence, during intubation, a straight laryngeal blade assists in proper visualization of the vocal cords. The overall shape of infant airway is funnel shaped as compared to cylindrical in adults. This is the reason why uncuffed endotracheal tubes are preferred in infants and cuffed endotracheal tubes in adults. The narrowest portion of infant airway is the cricoid as compared to the vocal cords in adult population. The tracheal cartilage in infants are not well developed as compared to the adults. Hence, a minimal negative intraluminal airway pressure may cause it to completely collapse and aggravate the respiratory distress. The functional residual capacity in infant is significantly lower than that in adults. Hence, a similar parenchymal lung lesion can cause severe ailment in an infant as compared to an adult patient. And finally, the ribs in infants are small and more horizontally placed as compared to well-formed ribs in adults which are placed at an angulation. This angulation helps adult ribcage to effectively cause bucket handle movement of the ribs to increase the tidal volume and eventually the minute ventilation. This is not possible in infants. Hence, in case of any respiratory distress, an infant has to increase the respiratory rate in order to meet the minute ventilation needs. So these were the characteristic differences in the airway of an infant as compared to an adult. I hope this short session will practically help you. I shall be soon coming up with other topics related to pediatric pulmonology, which I'm sure will make your understanding the topic much better. Thank you.